Hey there. I just wanted to thank everybody for joining us the other night. For those of you who were able to join us live, we really appreciate the questions. And for those of you who check out our content and continue to follow us, we really appreciate that. I wanted to go through and do just a follow-up slide, a follow-up video on calcaneus fractures, in particular talking about the axial view, because I think this can be a bit of an intimidating view if you're not used to dealing with fractures of the calcaneus and you get into surgery and you see this view. What are we looking at and what are we trying to fix? So if we break it down, you can see that here in the animation on the left side of the screen, you can see the pieces, roughly speaking. And I'm oversimplifying things here, I certainly admit that. If we look at what these are labeled, the lateral side's obviously the lateral wall, and that's most of the time where we're approaching this from. And then you have the central piece, and I'm going to model a joint depression, intra-articular calcaneus fracture. The sustentaculum is the medial side, and this is the piece that we'll sometimes refer to as the constant fragment, the piece that is usually pretty consistent, and we can oftentimes build to it, likely secondary to this, the thick, strong ligamentous structures that attach there. But on the other side of that, you want to remember that you have the neurovascular bundle, FHL, FDL, posterior tib. Mostly FHL is right underneath that area, and that's what we're concerned about. And then the tuberosity and what is all happening here. Well, let's keep in mind that this is an axial injury, right? So meaning that there's an axial load that occurs, and the talus basically creates this primary fracture line. And the primary fracture line comes through the posterior facet and then exits out the medial side of the calcaneus. So that central joint depression piece gets depressed down and the lateral wall gets pushed laterally. So it creates this widening effect. And then the tuberosity piece, that gets shifted into varus and it shortens like so. So now we get a widened heel. You have the lateral wall blowout, which is accentuating that. You've lost your height because the tuberosity piece has shortened and we have depression of the joint surface. So this is all on this axial view. All of this is happening. We can see this on the axial view. So what do we do to fix it, right? So we are trying to correct those deformities. So this is where oftentimes you'll see a Chance pin placed into the tuberosity piece. We talked about that with an extensile approach, and you can refer to that video. But we can also use this in some of the minimally invasive techniques. And this is where we talked about using a Chance pin. It's where we talked about using an external fixator. Sometimes we'll use some lamina spreaders. Sometimes we'll use a combination of a Chance pin and then a freer or joker into that primary fracture line to lever that out. Now, one of the things we did also talk about is preloading K-wires. And preloading K-wires involves placing a K-wire into the tuberosity piece. Like so. And what that allows us to do, because you look at this and think, gosh, what's the purpose of putting that wire in that place? Well, when we go to correct the deformity, we pull out the tuberosity, we regain height, and we correct the deformity, we narrow it, and then we pull it back in, pull it out of varus. Now our K-wire is positioned in such a way that we can advance that into that provisionally holds that tuberosity piece in place. Now we can come in, we can elevate the joint depression, we can push the lateral wall back, and then we can use the sustentaculum screw to compress this joint all the way into the sustentaculum. Now you can see in this piece here, now we have some crushed, some missing space, and this is where oftentimes we'll place some cancellous chips. We talked about using some artificial bone graft such as cement into that area to kind of act as a void filler and help give some structural support where the bone gets crunched down and we have some, quote unquote bone loss into that area. So this is what it looks like on the axial view. Hopefully that helps to just visualize it in that realm. I've oversimplified it. It's never this easy, but this is what we're trying to create when we get into surgery.